Good afternoon, and thank you for joining us. This is me, Miss Mary. See now? Good afternoon. This is me, Miss Rhonda B., coming to you from Voices of Mass Discussion. Thank you for joining us. I am here today with a fantastic researcher. I want to introduce you to her, Dr. Washington. But first, before we talk about what she researched and what she wants to talk to you guys about, because you know the foundation of the show is who is my guest, what do you do, and why should the viewing audience care? That's our foundation. But first of all, I always get excited when we have people straight from the community. You know, used to be a little Todd, and then now they're the successful, soon-to-be mega giant. This young lady is born and reared here. Were you born in the South Suburban area?
I was born in Ingalls Hospital, Harvey, Illinois.
Okay, she was born and reared here in the South Suburban area, and in Harvey, back in the day when Harvey was the spot.
Yeah.
So she grew up, went to the local schools here, went away. What college did you go to?
I actually didn't go away. I went to Chicago State University
for
my undergrad. Was in business.
Local.
Yeah. And then I went on for my master's degree at Governor State University. And then I got my doctorate from Central Michigan University.
Okay.
So yeah.
So you guys can't see Mary dancing back there. You know, she's a proud university.
University part.
She loves her town. Okay, so we will start up again. Her name is Knitasha Washington.
Mm-hmm.
She is an executive director, and she does research on healthcare. And then, Natasha, I'm going to allow you to tell us a little bit about yourself. She told us about you grew up there in Inglewood. You grew up there in that Harvey area, which reminds me of Inglewood. But you grew up in the Harvey area, so your background is basic, just, child growing up.
Mm-hmm.
And when did you decide that you wanted to go into healthcare? Were you at one point want to be a doctor, a dentist, or?
Yeah, I actually wanted to become a corporate attorney. That was my aspiration as a child. But I went down a non-traditional pathway. I was actually a teenage mom, so at the age of 17, I had a daughter and actually ended up in healthcare as a profession by default.
Mm-hmm.
Because I was looking for a job that would basically take care of what I needed from a financial standpoint without having to juggle 2 jobs and go to school.
Mm-hmm.
And I was able to find that during the time that managed care had spiked up.
Mm-hmm.
So in the early 90s, when managed care was really a big booming business back then, I ended up in healthcare. So that's how I started.
Oh, okay.
Mm-hmm.
So let's start a little bit back. When you were in school, were you just an average kid? Were you an honor roll student, or how was your?
Yeah, no, I was always at the top of my class. But I have to be honest, thinking or looking back, challenged
Mm-hmm.
a lot in terms of whether or not you're truly an honor student.
Oh, okay.
So, but I was always at the top of my class. But it was a different time.
Okay.
Because I remember. I was born in 72, so I remember in the late 70s and the early 80s where racial discrimination still, impacted our families. Now, obviously, it wasn't the same as it was, when my parents were coming up, but it did greatly impact, me and my progression through school.
Good girl, born in 72.
Mm-hmm.
My child.
Yeah.
So then which high school did you go to?
I went to Bremen High School in Midlothian, and I graduated from Bremen in 1990. And like I said, it took me 8 years to finish my undergrad degree. So like I said, went on to Chicago State University and finished up there in 1998.
Okay, so you went to, did you go straight from high school, or did you were at school for a while?
I went through a couple different smaller programs.
Mm-hmm.
So I had gotten a certificate from Robert Morris College, and I went to St. Xavier, also here in Chicago. Mm-hmm. That's where I actually started my business degree, mm-hmm. and then just because of expenses, ended up transitioning over to Chicago State.
So when you graduated with your undergrad from Chicago, was in business administration?
Mm-hmm.
Okay, so were you at one point planning on going to business, or you wanted to work for a business?
Well, I've always had an entrepreneurial mindset, mm-hmm. and so business was just a natural place to go. Like I said, I originally, my aspirations were originally set on going to be a corporate attorney, but I felt that, again, business was just a natural progression in terms of just the spirit that I exude, mm-hmm. and some of the things that I thought I wanted to do at that time.
And so now, where's your parents at in all of the back and, good girl, now pregnant, now, you know, but obviously you still was on the success track.
Yeah, well, I grew up with both my mom and my dad there in the household, and I think in terms of when I think about getting a little off track, it was during the time that my parents were divorcing, and I just think that you know that's something that we always have to consider as families, and I have such a great respect for the institution of marriage. You know now being an adult, but. Yeah, during that time frame was just a little bit difficult. Communication's a little difficult, and so absolutely. And then I had the teen years going on top of that. It was like, oh my goodness. So, but all in all, I can say that both my mom and my dad were always great supporters of me and my aspirations, and I can honestly say that you know, in particular, my father was just a real mentor and just really pushed us, irrespective of the mistakes we made, because we all make mistakes.
So now do you have siblings or you're not?
I do. I'm the oldest of four.
Oh, okay. Okay.
I'm the oldest of four. So
you were like the trailblazer. You had to lay the foundation for them.
Oh yeah, to some degree. And I have a sister that's right behind me, and I promise you, we look like twins by spirit and just even some of the things that she does. But I think that also speaks a lot to the character of the parents, you know, that we had. And yeah, absolutely.
Okay, cool. And so then you went on and got your business degree, and then did you work in the business world at all?
No, actually, well, I shouldn't say that. I did have a few jobs that I did take that were administrative positions, and they were in industry. But my first real job was actually in healthcare.
Okay. And so then you transitioned and you started working on your master's, and you received that in what?
I did. Master's in Health Administration from Governor's State, and I got that in 2002.
Okay. And so then now, today, are you working independent? Do you work for a corporation?
Yeah, I do consulting, and so right now I'm actually, I have a couple different projects. For the most part, over the last 15 years, I focused on cost management within hospital organizations. So, you know, I'm certain we all hear the stories about how the inflation of the costs within healthcare is just, you know, going up. And so over the last 15 years, I've worked in that space, partnering with hospitals to basically look at their infrastructures for fiscal management and to help them, you know, basically turn greater profits. While doing that, I've also done a lot of work in the space of healthcare disparities. So I've done a lot of advocacy work over the past 10 years in terms of minority health issues. And so recently, today I actually serve as an advisor for the National Partnerships for Patients, which is a federal campaign that looks at improving quality and patient safety across the United States. So
now, back 6 years ago, whatever, so when the Obama administration was coming to fruition, coming to life for real, so I can only imagine that must have gotten your interest twofold.
Oh yeah.
You know, being a young, you know, successful Black woman, seeing this unfold in your lifetime, and then also the whole big old thing was around the healthcare. So give us a little. So and then obviously I'm speaking for you. I'm assuming you follow the whole, you know, the pros and the cons and the debate.
Yeah, absolutely. So, you know, with the health reform is just really energized a lot of us, in particular those of us who understand health disparities, because we recognize that there's a tremendous opportunity for us to improve health outcomes within our minority communities, in particular within the African American community. And so, no doubt about it, that health reform was an opportunity, or is an opportunity, for us to basically take our communities to the next level. You know, greater health equates to a booming economy. You know, when I feel good, you know, I work better, and so productivity increases. And so, absolutely, from a minority health perspective, the Affordable Care Act has been a tremendous catalyst to pushing us towards where we need to go. However, the focus really right now is about access, and access is really one component, because we recognize that there are so many different variables that impact, improving health outcomes. So access, meaning, you know, having a card that says I can now go see a doctor, is actually just one component of it. You know, there's a lot of other aspects that we have to consider in that, my own ownership, my own, accountability in terms of whether or not I'm, supportive of exercise and whether I'm engaging my physician. Also, the quality of the services that are even provided within our community. So when we look at, the hospitals that serve our communities, are they adequate? Do they provide the adequate and quality service that we need in order to ensure that we are at a healthier state? So there's so many other components that we need to consider. I do believe that the Affordable Care Act, while we have, just focused on the access piece of it, there are other components of the Affordable Care Act that we haven't talked about that will also be a tremendous catalyst to moving our communities as well. One of those pieces is the workforce development component. I'm not certain if I'm certain that you probably have heard President Obama just recently asked Congress for dollars to basically fund workforce development, and in that workforce development piece of it, which is also in the Affordable Care Act, there is a component that speaks to the diversity of our workforce and the fact that they have within the law dollars that will be allocated towards supporting improving ethnic minority participation in these fields. So more Black physicians, more Black nurses, etc. And so that's a huge piece because our populations are becoming more and more diverse, and the research shows that an individual is more inclined to follow and to be compliant when they are with a practitioner that shares the same beliefs, has similar backgrounds, etc. And so because of those things, because we know that improving our workforce and the diversity of our workforce is very important, and that's also in the Affordable Care Act. So very, very excited about that.
Now, you know what, now that's actually a lot of information. So now your position, what you do, your knowledge base is with the institutions and the hospitals and the facilities themselves. So then what role, or if any, do you play in educating the public?
Yeah, absolutely. So within the National Partnerships for Patients, so the national campaign that I'm working with, that's exactly what we do, is we partner with hospital and hospital engagement networks to basically send that voice out in terms of some of the things that we need to be doing. So as an example, I design programs that are shared within the partnership. There are over 4,000 hospitals that are actively participating, and I have put together various agendas, various curriculums that are shared with these hospitals that promote the need to improve the diversity of our workforce, that also promote the need to look at the populations that we're caring for, understand those populations, and to basically design our programming around the population's needs. And so that's so very important as it relates to the ground level, because it's one thing, when we have it and we understand it from a research perspective, but how that translates from a practical standpoint is still a lot of work to be done there. And so that, basically it's the design of those programs and making certain that education goes out.
So now, do you go out to any of the schools or participate in the, because a lot of schools try to help introduce young kids into the different fields that they could go into. So do you ever go out to those health career and those, explain to them?
I've done some of that, and I think most of the work that I've done is really helped the younger folks understand the broad scope of types of careers within healthcare.
That's what I'm saying.
Yeah, because there's so many different spaces, and I think that's one of the pieces that I love about healthcare, is that in and of itself, there's so many different areas that you can actually go into, and me, being trained from an administrative standpoint within operations, but then now taking that, that training and pushing that up the ladder from a policy perspective is the work that I'm doing. So really just broadening the understanding of all the different spaces that a person can go into.
And I can see so many young people not considering it, because basically when you're young, all you know is what either you've heard in your household or what you see on TV. And so the only thing you think you know is that you're either going to be a doctor or a nurse,
right,
maybe an orderly.
Right.
And that's only maybe, because you very seldom hear it, even though they exist. So, but And then we meet someone like you who sort of went through the medical field through the back door.
Yeah, yeah, yeah.
You don't have to take anybody's blood pressure or stick them with a needle, but you're still in the industry.
Absolutely. Well, one of the other programs that I designed, I am the immediate past president of the National Association of Health Services Executives, and in that role between 2011 through 2013, well, actually 2010 through 2013, I actually designed a legislative intern program where we recruited young students that had an interest in policy, had an interest in what was going on within health reform, partnered them with legislators here within the state, so that their acumen would grow from a business perspective, from a public policy perspective, from a healthcare perspective, and so that they would be able to transfer that knowledge into the work or their training in healthcare. One of those individuals, I'm very proud to say, is State Senator Toy Hutchinson. We had a legislative intern with her, and so you know, having someone in her office working with her, understanding things from the ground level, understanding, you know, what her district you know, needed, the needs assessment, and then being able to translate that back was really good grooming for that individual from a policy perspective. So yeah, absolutely, just trying to share the knowledge so that people do understand, you know, that healthcare is not just that point of service delivery piece.
Okay, yeah, and that's so huge. And like I said, there's so much, because even if you go into a hospital, you have to encounter so much. I mean, even not even going to the hospital, it's the doctor's office.
So
I mean, someone that take that call, which needs to be knowledgeable.
So true.
You know, then you have that nurse, you know, of course, which needs to be knowledgeable. You have the doctor, you have the aftercare, the follow-up care, and then you have all the in-between.
And then all the measures, and what the part that I focus on is all of the measures and how we look at the indicators in terms of whether or not these programs are good, bad, or indifferent.
Right.
So, you know, looking at the mortality rate, looking at, you know, the length of stay, looking at, you know, the cost a perspective of, you know, whether or not within this particular case it costs us more to deliver care for this type of patient as opposed to this type of patient. So that's where the business piece of it comes in, is to be able to sit and translate that information and to work with the medical doctors to improve, you know, our operations.
And then you have the whole argument about people, once the Affordable Health Care Act came into fruition, would not be so dependent on the emergency room. But then, of course, now that the ball is rolling, you know, those who do the research are saying they're not seeing that as the case.
Because education is such a big component to that.
Yeah.
You know, I do what I know, right? And so until we really, from a grassroots perspective, begin to change the behaviors, and that's only through education, you know, that we're going to begin to see differences. Many of those individuals don't have a relationship with a primary care physician. And so because I don't have a relationship, but I know I'm ill, then, you know, I need to, this is my point of access into the health system. So there's still such a tremendous amount of work that we need to get done.
And I can see that, because without the relationship with your own personal doctor, you, in your mind, what difference does it make?
Absolutely.
You know, a toeache is a toeache. You know, whereas based on you guys educating, then people understand that, okay, it's a pain in your toe, but with your own personal doctor, he'll have other history. So then he'll know whether the pain in your toe is nothing to worry about versus let me look into something else. And so, and before we started the show, we were with a friend of mine here, Mary. For those of you guys who watch our show, you know she's a proponent. But the three of us was having a conversation about the things we don't know when we think we know. And then each generation, things are, even though they stay the same, they're a little different. Because prior to your generation, like with your mom, and actually prior to your mom, the community, especially low-income and lower middle-class communities, would have their own physician. And then they would have a particular doctor.
In the community.
Right, in their community. And then they would have a particular doctor that they would take their children to the point where they may have been too obsessed that if they didn't get to that doctor, then they wouldn't go to a doctor. Because coming from the South, a lot of them migrated from the South, trust was such a factor. And so they were not going to go to an emergency room and now have to depend on these whole sea of nobody, people they don't know. So, but then you fast forward and you get, you know, my generation and then the ones following, and not so much.
Well, what we're seeing, actually, I'm involved in some research. There's a project that I'm working on, Mega Faith Meets Mega Science, with Bishop Larry Trotter of the Sweet Holy Spirit.
Okay.
So I'm operating basically with his congregation and a number of researchers, University of Illinois, University of Chicago, Advocate, Rush, etc. What we're actually finding is that trust is not only the one of the factors that also impacts our access, is that there are so many other pieces that also keep individuals away from a social economic standpoint. And so we understand the social determinants piece, but you know, if I don't have food on my table, how can I be concerned about whether or not I trust you, right? So trust is really not the factor. It's just that my concern is the food not being on my table, or joblessness, concerns about foreclosure, etc. So when those are my primary concerns, it's not so much that I don't want to trust you as a physician, because I recognize that you've been trained in your area and you're an expert, etc. But it's hard for me to get at that level of engagement with you because of these other things that hold me back. And so that's one of the areas that we're beginning to research. How much does that actually impact? So is it really trust? Or is it some of these other social factors that we recognize that are out there that do impact our level of engagement?
So are you saying that is the reason why you just don't go to a doctor for a routine checkup, or when you're ill?
So a good example is that it causes significant delays. So in other words, it's not so much that I don't trust you as my physician, but this situation that I have has caused a significant delay in terms of my access to you. A good example is I just hosted a breast cancer summit over at Roseland Hospital, and there were a number of stakeholders that came out: the Metropolitan Breast Cancer Organization, the Chicago Department of Public Health, Illinois Department of Public Health, so on and so forth. And one of the things that we clearly heard in the room, we asked for some patient advocates to come and just talk and tell their story. And both individuals, one that's actually is clinically trained, and the other one that was not, and both of them spoke of their delays in just dealing with life. And so when I was thinking about Women's History Month, this being Women's History Month, and many of us professional women, we are the most inclined to have those types of delays because of work and because of children and all of these things. And so what I'm saying is that there are a number of other factors that do influence these delays, and those delays actually do factor into our outcomes. So whether or not I get my mammogram timely, right, does factor into my outcome in the case that there is some growth. And so it's these other factors that we're looking at, attempting to measure and understand how much of it is that versus actual trust. When I think about my father's generation, now that trust was a much bigger factor there, because the relationships didn't exist as much to the point that you were making, and so because of the lack of those relationships, the trust factor was much bigger there. But what we're seeing now is that there could be a shift going on, and that's a part of the research that we're looking at.
That's interesting. The fact that someone even specializes in the research, because you don't know what you don't know.
Well, and what's so important, Rhonda, and what I really appreciate about this is that it's about our behaviors, right? And if we understand who we are as people and understand our behaviors a little more and what causes me to do the things that we do, or the things that I do, then those things do influence our health outcomes. And so how can we create healthier families, create healthier communities? And it's really about understanding the dynamics of the issues and the perspectives in which we engage. So that's the reason why I enjoy that work so much, because when we look at minority health issues in general, and recognizing the tremendous opportunities that we have to improve our health outcomes, it's about taking a step back and really understanding what are those issues, or what are those variables that impact the reasons why we do have poor outcomes.
Yeah, and that what I would think like I don't do any research, so I don't know. But I would think I'm from like my mom's generation to myself. Like I say, when I grew up, I knew my mom had her particular doctor. She was not going to go anywhere else.
And that was it. That was it.
They could say, okay, you about to lose your limb.
That is so true. That is so true. My grandmother was the same way.
He'll be back in 10 days. So you need to get
and she wasn't going nowhere until
some duct tape.
That's right.
You know, but then by the time I became an adult, then that's when the onset of the HMOs and things were changing.
Change.
So any time, so therefore it was no longer about the doctor. It was about a doctor, but not the doctor. And so I just, if I'm not a doctor goer, so to me, it's just that I like life simple and I don't like hassle and it's just too complicated. You know, I can't go to this doctor because of this, so I need to go to this doctor just to go to that doctor.
Referral to go to this doctor,
right.
Absolutely.
And so then you have a person with my mindset, so just end up wanting to know doctors. You know, so by the time they saw me, it's like, oh, okay, we need a prayer. You know, because she came a little late. You know, and then that's like my generation. Because we recently lost my brother to cancer. And years ago, a doctor had told him that he had a touch of tuberculosis.
Okay.
And if you were, and I'm saying this to say, and for the public to understand, that if you had a regular doctor like how my mom and them had, you would have gone to the doctor on a regular basis. And so therefore he would have either kept noticing that or kept reminding you of it. But because he only was at the doctor at that time in the emergency room, he was in the emergency room in Cook County when they told him that because he had broke his rib or his nose so in his mind, I'm not here for that, so it's not bothering me. Never did, 15 years went again, so back in the emergency room they think he's having a heart attack, which he was. But then, of course, then they discover now you're also riddled with cancer.
Well, the other interesting piece of around is also the quality of the care that we receive. So, and I completely agree with you. I remember, coming up, and my mother had a particular doctor. There was a particular health center that we went to, and then you're absolutely right. Things change, but we also have to look at the quality of the service that's delivered to our communities, and that also is impacts our health outcomes. So, as an example, my father, in 2009, I lost him to a medical error. And so at the age of 59, he had went into the hospital to have a surgery performed, and he did not survive post-surgery. And the actual cause of his death was related to a hospital-acquired condition that is not supposed to happen. And so we do have to look at the quality also of the care that's being provided. And what we do know is that the access to high-quality care has not always been there within our communities. And so that, again, that's just another factor that we do need to consider.
So that's it. So that's almost like a little personal with you. You want them to get it right.
Absolutely.
Because you can't undo what happened to your dad, but you don't want it to happen to another family prematurely.
And that really was an eye-opening experience for me, because again, I had always advocated on behalf of diversity, on behalf of minority health issues, but the quality aspect of it, I never really spent a lot of time understanding that component of it until it hit me personally. And then I realized in that we have some huge issues nationally as it relates to patient safety and quality. And so now we're moving into more of an environment where consumers are asking for more transparency of information, and that's why when you hear about being able to access your medical records timely, things of that nature, because we do live in an era where we do need to be concerned about the quality of the service that is provided to us.
Now, let me backtrack a little bit, because your foundation is that Harvey area. Now, Harvey, and at the time when you were growing up, it was a decent area, middle income, it's just like the mecca of the suburbs at one point. But even though now it's no longer the mecca, it's the mecca, but of a different type. But the community as a whole is highly vested in healthcare. Because as you were born in Inglewood, and Inglewood has made a total transformation from the time you were born until today, and it's like a highly recognized facility. But in addition to that, because I have to take public transportation, so I take the bus through Harvard.
Okay, yeah.
So in addition to that, there's all kind of medical centers.
Right.
And then when my brother was making his transition with cancer, there's a family Christian medical center there. And they went, and the doctor, told him, unfortunately, it's too far gone. And then, but the thing that stuck with our family is they prayed with him. The further thing, and I'm the one who drove him there, so I'm thinking like, okay, now this is not making much sense. The man's like, okay, you're not gonna make it, but but anyway, but the fact that they were so, this is my point, the fact that they were so concerned,
right?
Because actually I didn't even see why we were going, because the Cook County Hospital had already told you it was terminal. But then he was referred to a doctor there, and the guy's like, yes, come on out here because I want to talk with you. You had the stuff that they already transferred over the computer, but you still wanted to meet with him to just tell him, that they were making that you're going to make a transition, things happen, blah, 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 blah. But they were so concerned. And yes, it was like, and then he was telling him, like have your family come. The members of your family come, because obviously, if you have that cancer gene and trait, it's in your family. And so why wait? Sort of like, in other words, okay, you're going to leave here, but try to save which he came and had the conversation. Nobody listened, but he did come and had the conversation, and then I was trying to tell my family, this is for real. It's not him.
And that's the point that to your point, that's the area that I focus on. Why, when he came and talked to the family, why didn't we move?
No.
Why didn't we immediately go into activation and immediately, and it's the same thing with my family, and so that piece of it as patients and how we engage the systems, we need to spend more time educating one another and understanding, what's available in the community and the resources that are available, and aligning ourselves, to your point about your brother, in developing a relationship, with a provider, so that you can have those educated conversations about what's going on with you and the way you feel, etc. And you want to feel comfortable.
Right.
You want to feel comfortable talking to somebody.
But I'm saying this in light of what you're saying about you guys are doing the research as to why people don't. And then the fact that now that the Obamacare thing came out, and research says they're not running to get their own doctor, so it's like, okay, we're missing something here.
And to your point, one of the primary groups that we're really trying to get the word out is the group between the age of 18 and 34, and that's because of those individuals that have already gotten into the exchanges. They tend to be older individuals, and so from an actuarial standpoint, we want to make certain that we have a pool of people that's well represented of all age groups.
So, and that's something you can, since we had the opportunity to speak to someone of your stature, explain to the public. Because the older person I can see, 40 and better, because you're figuring either something's wrong with me and I don't know it, or it will soon be. But then for that younger group who's in your prime, you're more focused. Now that's why I can see with your research, what you're doing over there with the church would be focused on, because you're the one in your prime and you're focused not so much on losing your home, but getting a home. And so the last thing on your mind is going to the doctor and I feel okay. So, maybe you could speak to that group and, help them understand why it's important. And I can speak to it from a personal perspective, because like I say, that doctor, which struck us as odd, just really was having a conversation with my brother about having your family know to go develop a relationship with the physician. That's pretty much what he told him. He said, because even though you're dying of cancer and you're associated with the smoking, he says there's millions of people smoke and don't die of cancer.
That's true.
There's a gene in your bloodline that's going to be there whether somebody smokes or not. And then true enough, I said, he came back and had the conversation. Not a single person, including myself, went to the doctor. And then, but in our family, we have heavy cancer. So you would think that based on a doctor, a real professional, and he was an African-American doctor too. And so that's what he was telling him about our heritage. That was another piece that just struck me as like, what doctor takes up that much time, especially talking to somebody that can't help anyway. When he brought up about the heritage and the bloodline and the high blood pressure and the importance of the annual physicals because of traits that you have just, not being sick. You just naturally have these traits. And if you have the regular physicals, then supposedly, I guess in theory, you can watch those patterns and try to be some preventive medical.
Well, I think you made an excellent point earlier when you started talking about educating the youth, and the earlier we educate them. So beginning to really educate, kindergartners and first graders to the point, yeah, absolutely, to the point that the health awareness component of it is trained earlier. Because think about it from the standpoint of being 18, 19, 20 years old, your health awareness is different from when you're in your 40s, right? Because for the most part, you're fairly healthy individuals there. And so unless you have something going on where you've been diagnosed, etc., for the most part, you tend to be healthy. So, but where the training needs to occur, where the education needs to occur, is for that group to understand that maintaining that level of health requires certain things. And so even at that age group, to your point about, finding a physician, just going in for an annual checkup, getting your annual blood workups, talking to someone about, various symptoms, etc., is very important for the maintenance of health. And so it's kind of like that, what we see with that particular generation is just that because of their awareness of their own state of being healthy is very different from the individuals that are signed up, because those individuals that tend to have more chronic diseases, I have high blood pressure, I have diabetes, etc. And so for them, their state of maintaining health is very different. And so we need to actually spend more time educating the younger individuals so that it's trained up earlier to engage.
But I know one of the things, like from my age group, when we were growing and becoming adults, like I said, coming into the work world, getting your insurance, and then at that time they started with all that HMO, and you didn't have a doctor, so there was no emphasis on getting yourself a doctor. So therefore, it seems like it was more, the procedure was more, unless you need to go to the doctor, then don't go, because it's expensive.
Well, even and I worked, in managed care. Even in those designs, they did establish it where it was hopeful that individuals would actually still continue to go for those annual examinations. But to your point, I think where it got a little bit dicey and a little bit off track was at the point where there is something wrong, how I get access to that next level of care became very convoluted, very convoluted. And so many people, there are all these delays. So as opposed to going through that convoluted, confusing system, then I kind of stay